Hi, welcome back to Word 101. So, today we'll talk about something that looks simple on papers but confuses almost every one of us, everyone in the words: hyponatremia. Now, the textbooks makes it sound very algorithmic, but at the bedside, it's far from it. So, we're going to slowly break it down how we actually manage hyponatremia in real life and what matters and what doesn't matter, and how not to harm the patient and what to do, and how is it different from the textbook when it comes to real life. So let's assume that we have an hyponatremic patient. So first step is that do not jump to treatment. Yes, the first thing that we do in the ward when sodium levels pops up low is that we panic and then we're like, okay, give him NS. Don't. You first have to ask, is this real or pseudo hyponatremia? This is very important. As soon as you see someone is having hyponatremia, check his glucose levels, check his lipids, check his proteins. Importantly is glucose, because if glucose is high, what is it going to do is that it is going to suck the water from the cells and dilute the sodium around it in a very simple way. So if glucose is high, correct the sodium first before labeling it as a true hyponatremia. Now, textbook says us to calculate the corrected sodium. Yes, we do that, but in real life you do it because it changes the whole diagnosis. That's the main purpose. Then what do we do is that we check what's the patient's volume status. Textbooks divides it into hypovolumic hyponatremia, evolumic hyponatremia, hypervolumic hyponatremia. But at bedside, it is very unclear most of the time, so we have to look for the practical clues. It's not crystal clear, just like how we read it in the books all the time. If the patient is having dry tongue, low blood pressure, and flat neck veins, think hypovolumic hyponatremia. If the patient is having puffy eyes, edema, ascites, or symptoms of right-sided heart failure, think of hypervolumic hyponatremia. Everything looks fine, but the sodium levels are low. Usually it's SiADH. Think of SiADH. Now the next part that you're going to do is that you have to question why. The why question. Before you grab a saline bottle, you have to ask, why is it low? Why is the sodium levels low? Diuretics can play a role, vomiting can play a role, heart failure can play a role. Is it cirrhosis, or is it just because the patient is having post-operative fluids if he's an inpatient? So because treating without fixing the cause is like filling a leaking bucket. So find out the cause first. Now, the textbooks loves the formulas, and what textbooks don't tell you is that the formulas rarely work perfectly on a real patient. Yes, they do, but rarely works perfectly on the real patient. Textbooks tell you that increase sodium by not more than 8 to 10, right? 8 to 10 millimole in 24 hours. That's true. But in practice, we don't chase the exact numbers. We chase the stability of a patient. Is the patient responding? Not responding. We recheck the sodium every 4 to 6 hours in critical cases, not every 24 hours. Every 4 to 6 hours if the patient is in a critical status. And we watch the trend, not a single number. You have to make sure that your patient is responding to the fluid that you're giving. And the books, they say use 3% saline for severe symptoms. In reality, most of us start with 100 ml bolus of 3% over 10 minutes. And then we check the response. And then we repeat if the symptoms persist. We don't pour liters of it, liters of 3% NS. So you titer based on the symptoms like confusion, seizures, GCS, according to that. So if the patient is vomiting, if the patient is hypotensive, or if the patient is dry, normal saline is your friend. You're replacing the volume. The sodium will correct itself by ADH falling. So when you give them NS, what happens is that the sodium will correct itself and the ADH falls. If the patient is having SIADH, syndrome of inappropriate antidiuretic hormone, he's evolumic. Normal saline is going to worsen the sodium levels. Here, the real trick is to do the fluid restriction to the patient. Not easy, especially when the patient keeps asking for water, but yes, it definitely works. It definitely works. And the third case, for example, if we have a patient for heart failure or for cirrhosis, you have to treat the underlying cause of hypervolumic thing. So give loop diuretics, consider giving them vasopressin antagonists if it's available in your medical setup. So don't forget to stop the cause first. Thiazides are very classic culprits for hyponatremia, so make sure you're taking a thorough history of the patient's drug use. You will be surprised how often sodium normalizes just by stopping a drug, if that is the cause of the hyponatremia. Now, the fifth point is that the dangerous mistakes that the doctors or any of us can make. Don't correct hyponatremia too fast. You're going to risk the patient with osmotic demyelination. Never push the sodium, the 3% saline blindly. And do not rely only on the formulas. Watch the patient's neurological status, because sometimes we run behind the formulas and the patient might be having certain side effects. And don't miss cortisol deficiency. Always check morning cortisol in unexplained cases. So make sure you're holding on these dangerous mistakes that we may make during correcting hyponatremia. Now in the ward, our real workflow looks like: confirm through hyponatremia, assess the volume status of the patient, identify the cause of the patient, the cause of hyponatremia, treat the cause first, choose the fluid carefully, and monitor sodium and the neurological signs every few hours, not 24 hours. If the sodium is not improving after 24 hours, reevaluate the patient. It means you must have missed something related to it. So that's hyponatremia beyond the textbooks. In exams, they want the algorithm, and in the words, patient wants sense. So always remember to stay logical, stay safe, and always reassess when the patient comes with hyponatremia. This is Ward 101, where we bring textbooks medicines to real life. See you in the next video.